So Mike Chernew, thanks for being with me. So who you are, what do you do?
I'm Mike Chernew. I am an economist. I am a professor of healthcare policy at Harvard Medical School. In terms of my research life, I study spending growth, payment reform, changes to benefit design, things like that.
Mhm.
In terms of my
Medicare and Medicaid and also in private insurance.
Actually, for benefit design, largely in private insurance. For payment reform, I started doing stuff in private insurance, and now I do most of my work in Medicare. I don't do that much in Medicaid, actually. I've done a few things in Medicaid. Of course, benefit design is less of an issue in Medicaid writ large because there's not as much reliance on out-of-pocket spending. In terms of my policy life, I guess there's two things that I do. I'm chair of something now called MedPAC, which is an independent congressional agency that advises Congress on Medicare policy, including payment. And I'm the vice chair of the Connector in Massachusetts, which is the Affordable Care Act exchange, the marketplace here in Massachusetts.
By the way, for our students, my brother-in-law Vincent wanted to join us and keep us company during this call. So just if you're wondering who my bodyguard is, that's who it is. Man, you want to wave hi to everybody? There you go. So you're a health economist. What aspects of the basic microeconomics framework do you find most useful in your day-to-day work?
Well, I think there's a lot of aspects of economics that are broadly applicable. The stuff that I think is most important relates to issues around price theory and unintended consequences. So, for example, I do a lot of work on payment reform, and a lot of people think of payment as a way of transferring money from one group of people to another group of people, say Medicare to doctors. But I think the economics framework would tell you to think about those prices as incentives. So, for example, if you want to give more money to hospitals or to nursing homes or to any other group, you could do it in a number of different ways. One way to do that is to pay them higher prices. The problem with doing it through paying higher prices is you encourage utilization of those services that are high priced. And so you have to think through the supply side response to the incentives associated with prices, not simply the transfers that occur if you give one group more. We do a lot of work in Medicare now, in MedPAC in particular. We have a whole agenda on supporting safety net providers, which is particularly important. And one of the core issues is how you think about what form those types of payments should take. So those are the type of things that are probably the most important in what I do on a regular basis.
You know, when you mention safety net providers, one of the debates that rages inside my head is whether we should have safety net providers as a tier of. I mean, everyone needs to get medical care, but when I looked at COVID, and I looked at some of our public hospitals and some of our community hospitals that minister to the poor, they had markedly worse outcomes for COVID patients than U of C, Northwestern, Rush, and it's basically basic staffing issues in the ICU and things like that seem to have led to an enormous difference in health outcomes, and particularly because Medicaid and Medicare pay such different reimbursement rates. How do we make sure that people who go to safety net providers are actually getting the quality of care that they need to get? Even if it's just a question like in the ICU, just do we have enough, respiratory technicians there to properly position the bodies and all that other stuff?
Yeah, so I mean, obviously these are very complicated questions. So I'll give you a few broad answers. One issue is when you think about the way you define safety net, and I would make a broader policy point. More often than one would like to admit, policy arguments involve differential understanding of the same terms between people having a conversation. So people that otherwise agree will then disagree. So if you take the issue of safety net providers, and I mentioned safety net providers, which you might think totally reasonably means I meant safety net providers. What actually we mean when we talk about safety net providers is providers of any type that are delivering care to vulnerable populations. So one of the principles MedPAC uses in other contexts is to avoid cliffs. And there's this tendency in policy to create discrete categories of groups and make one group favored and one group not favored, which creates a lot of incentive issues around the details of that cliff and the details of the definition of which side of it you're on. And so a lot of the work that MedPAC does tries to smooth that out. So instead of giving a lot to a group of people defined as, quote, safety net providers, we think a little bit more about how many, people, vulnerable population, people who are members of vulnerable population, are you treating? Questions like that, and try and make it a little bit more continuous.
Got it.
The other reaction to the comments you made, and then I'll try and actually answer your question, is there's another aspect of economics that sort of transcends price theory, which is a broad way of thinking, and it really focuses on aspects of the counterfactual. So when you think about support for the safety net or not, you could focus on the fact that under any level of support for the safety net, they may not perform as well as providers that are serving much more advantaged populations, in part because the outcome of care somewhat depends on the nature of the resources that patients bring to the care process, and in part because of the resources you've devoted to the organization. The counterfactual is not in many ways to spend the money to essentially make every safety net provider, every provider serving low or vulnerable populations, low ICS or vulnerable populations, make them behave exactly like others. The counterfactual is often spending less. And so our arguments, we should not spend less, we should spend more. So how you would think about various policies relates to that. So the question then becomes, you ask the question specifically, how do we ensure that the care delivered in these organizations is good? And I'm not sure, again, what words to use, because obviously care can always be better. It's typically some combination of providing the resources necessary to deliver that care and having the right set of quality measures and metrics to make sure that the right care is then delivered. And in the policy space, where we are transferring money between groups in a whole bunch of ways, it's often difficult to ensure that people get the same care in provider X versus provider Y. And quite frankly, people don't get the same care in different parts of the country, even if you were to look at the most advantaged populations. There's widespread geographic variation. So I think the question is, how do we transfer as much money as we're willing to pay? That's a political decision, and do it in a way that encourages the best outcomes as possible. So that involves some quality measurement issues. MedPAC has a whole process for thinking about how to deal with quality measurement and adjusting for differences in SCS, for example, across different providers and the SCS populations, the SCS of the populations they serve. And then, in some sense, we're always going to be able to do better. It's a question of trying to encourage as best you can the best outcome for the resources that organizations have. And, I think the COVID pandemic really highlighted a lot of challenges that we had in our delivery system that may not have been apparent, or at least as apparent. I think they were actually honestly quite apparent, maybe not as apparent or as starkly apparent as was clear in the COVID pandemic.
Let me make 2 points on that. But one of the things, when I did a paper in Health Affairs where we interviewed a lot of key informants about mortality disparity in COVID, and, in critical care, and then the most common comment we got was, there's nothing COVID specific about the COVID disparities. That if you have it's people in acute respiratory distress syndrome, and it's always quietly been happening. And these disparities in care quality. But one clear incentive issue that bothers me a lot is, if you think about incentives imposed on state governments, not on individual healthcare organizations. Suppose at the margin I could spend another $1 on Medicaid services for poor people, or I could spend another $1 on the public health infrastructure. If I spend another $1 on Medicaid, I get a really nice federal match, particularly if I'm a low-income state. I could be getting $3, $4 from the federal government for every $1 that I spend. So of course, I'm going to spend more money on personal health services rather than to hire more people to do like case finding for HIV or public health outreach or whatever else I'm doing that's not a reimbursable service. And then COVID hits and we discover, wow, our public health infrastructure is terrible. We have no PPE, we have no infrastructure set up to really respond to a public health emergency. And it seems like that is unsurprising when you think about the way that we rely on states to bear huge responsibilities for that, and we really disincentivize them from investing in all these boring until it's not kind of activities to build up the public health infrastructure. I wonder if there's some way what your take is on that. Am I giving sort of too glib a statement about
I mean,
those?
I agree. I agree fundamentally with your point on incentives. So that fits into the first question you asked about the role of economics. The incentives matter. I'm not sure in this particular case if it's fundamentally the incentives that are driving the way that the states invest their money. There are obviously some rules about how much they have to devote to the Medicaid program, but there's also issues that well between a statistical life, an identified life, and things of that nature that make investments in public health challenging. And there's some other broader things outside of economics about how we feel about investing in public health. In fact, as a separate point about economics, I would say classical economics tends to think in a very individualistic way. We have individual actors doing individual things. It is often challenged by broad provision of public goods. In fact, there's whole sections about why we undersupply public goods in economics, and public health in many ways is a classic public good. I think one of the challenges in public health as well, two challenges. One is there's many public health interventions that we don't fully understand the cost effectiveness of. And it's not completely clear to me if we had spent a ton of money on a range of PPE that would have been appropriate for the COVID pandemic, that the challenge we would have faced would have been the COVID pandemic, and we would have had a problem with, oh my gosh, we've been all this time preparing for a viral pandemic and we haven't invested enough in something else, or worse, we spent all this money on respirators and they've sat around, we didn't know when it would hit, sat around for 10 years, they're not in that much repair, we in a good state of repair, we could have used that money at a particular point in time for something else. So there's a lot of room for analysis. In fact, I saw a very interesting seminar about resilience, and the gist of the seminar was you can try and plan in advance for all these public health things. You're always going to get that wrong. You need to make sure you set up systems that will be resilient when one of the pandemic hits. And I think one of the other things, and again, Harold, I would defer to you, that happened in the case of the COVID pandemic is for a range of reasons, including the severity and the rapidity of the pandemic, a lot of the decentralized issues across the country. I don't think as a whole, we were able to muster the resources we had in a way that would have been as useful. And in many cases, in part because we weren't sure what was going on, there may have been missteps in how we spent the money that we had. So I, broadly speaking, have been a supporter of public health. You and I both spent a lot of time together in the School of Public Health. And I do believe it's important to invest in public health. I also believe it's important not to oversell what public health can do. Often we hear stories that if you were just to provide these level of services, we would save a ton of money. And for the most part, that is seldom true, unfortunately. That's a broadly speaking cost effectiveness issue. You probably know the Camden Coalition story, which is pretty well known now, about providing social supports for people on the theory it would save money. Early evaluations were quite promising, randomized trials, much less so. We've heard the same narrative around a range of wellness programs where we could, the appeal is if we could only keep people healthy, we would not have to spend on healthcare, which at some levels just true. Obviously, the problem is we haven't yet found the intervention that makes the math of that work.
So you've got a couple of things going in that. One is the benchmark that you have to save money. If we wanted to save money, we could shoot the patients. That would definitely save money. Right. When we have a new heart attack treatment, and one of the things that you and I have studied and written about, but our students haven't quite seen yet, is the literature on medical cost effectiveness and willingness to pay for a quality adjusted life year and so on. We're willing to pay quite a bit for, if you say, how much are we willing to pay for a new cancer therapy? We're willing to pay quite a bit. And there's no particular reason that we should hold public health to it has to save money standard. And I think one of the ironies is that in public health, we're tempted to argue that public health saves money, which then creates an implicit standard that that's the way it should be judged.
That's true. And that's the same, by the way, holds true for primary care.
Yeah.
I think that's right. I think the challenge that arises as we get into public health, and this is true when the government's involved in the provision of any service, is what are the bounds? And I think public health begins in this space to move, and healthcare in general has moved towards expanding the set of services we consider health, because your health is affected by so many things in your life. So to give you an example, when we started doing our work on value-based insurance design, which was very much in the context of traditional medical services, we were motivated in part by making sure that disadvantaged populations weren't being charged a lot out of pocket to access care that were very high value. I might add, not cost savings, but very high value. And in fact, when we do things here in the connector where we think about how we set up our benefit packages in Massachusetts, we put all of our policies through an equity lens, which interpreting is a little harder to do than to say. But in any case, what that means in practice is we look at services that support diseases that a lot of the vulnerable populations that get their insurance on the connector serve. Good.
Can I give an example of a VBID type example? You can tell me if I get this right or wrong, just so our students, So like, for example, you don't want to have a copay for insulin that is financially punishing for a person of modest income, because we know that somebody who has diabetes and needs insulin, we do not want those people to not take an appropriate medication because they face a financial bind for doing that. And so we might say, well, if we're going to use the financial incentives that you'd use a generic rather than a brand name drug for something that would, that's a bioequivalent, that would be perfectly sensible from an economic perspective. But we don't want to put a barrier up for some really important like antihypertensive or something like that, where we can reasonably predict that someone of a modest income might end up not getting a useful medication.
Yeah, so that's right. And just as an aside, insulin is the classic example. On the exchange, that was our first example, putting out-of-pocket limits on what plans could charge for insulin. The Inflation Reduction Act also has a component where they limit what people can pay out of pocket for insulin. And in fact, Section 2713 of the Affordable Care Act that I was tangentially involved in, but was really driven in part by my colleague, Mark Fendrick at Michigan, made a whole slew of high-value preventive services free. That's actually now under legal challenge, which is a longer topic of conversation, but it all has this flavor of that. And I think that's right. But all of that fits into the category of real medical services. The interesting thing about public health is we've now moved into both public health, but also a whole range of other services. The sort of classic example is if you give someone an air conditioner, you can avoid an emergency room stay. And so that might push you to give a lot of people air conditioners or give a lot of people housing, all of which, by the way, are noteworthy. But you end up in a world in which we're funding that through taxpayer dollars, trying to figure out what the boundaries are. And you end up, in situations where someone's like, why should I pay for my air conditioner? Well, I have to pay for my air conditioner and I have to pay for someone else less fortunate air conditioner. So ignoring the did you save money, which actually is much harder to prove than the story would suggest, it's very difficult when you move outside of healthcare services towards other aspects of our society that influence people's health.
One of the ways that calls to mind, and we'll get to this later in the course than many of the students will probably watch this video, but we have this very targeted sense of egalitarian values in social policy, where I think we really do believe, almost everybody believes, everybody should have health care that they need. I think pretty much across the political spectrum, people are like, if you have cancer, you should get appropriate cancer care. There are very few people who say straight up, if you can't afford, chemotherapy, you should die. That's, but we're ambivalent about that, about the air conditioner, and about things that are the boundaries of our egalitarian values. It gets complicated, and you sort of say, well, I'm not sure I feel the same way about every need that someone has. If you say to people, do you support like a universal basic income? Many fewer Americans would support that. And many of us would be more ambivalent about that than we would be about, do you support universal health care coverage?
Yeah. And remember, I think in my policy activities in general,
Mhm.
it is really important to never forget that there is someone paying for the things that you think people should have. There was no one just sprinkling money in the world. And often the policy debate focuses on the value of the things that we think everybody should have, and not the mechanisms by which we finance that. And that becomes complicated, and it begins to blend into broader discussions about individual responsibility and a series of other things that, again, I think there would be a lot of agreement across the political spectrum on parts of it, and then disagreements at the margin around a good example would be work incentives related to Medicaid, right? So we would, I don't think anyone from the left or the right would broadly be supportive of a system where we designed a Medicaid program to discourage work. And we could identify the theoretical position that Medicaid discourages people from being in the labor force. There's a whole branch of economics around the implicit taxes associated with these transfers, and gets into issues of earned income tax credits and other types of things.
Yeah, we just talked about that last class session. Yes, go ahead.
So there's a lot of discussion around that. In some sense, I think the most powerful part of economics becomes the empirical analysis to understand the magnitudes of these things. The same holds true with minimum wage, right? So we could argue, do we support a higher minimum wage? And that argument is pretty straight. The arguments around that in many ways are pretty straightforward from an economics point of view. If you make employers pay people more, they'll hire fewer people, which is broadly true. The question is sort of how many people, and what are the disincentives associated with the taxes? And the problem, for example, with the debate on tax policy, and I am not a public finance economist, and I don't want to get into the debate on tax policy, is we know if taxes are 100%, we will really discourage work and everybody will be worse off. We know if taxes are 0%, we would not be able to finance any of the public goods that we need, roads, defense, all the things that matter. And so we end up in a world trying to figure out where on that spectrum we want to be, and how much do we believe individuals should have to pay for the well-being of others in society. And there's a difference fundamentally between roads and healthcare, because one of them is a broad transfer for society. The other one is really a much more, is motivated by a much more distributional view of how society should work. And again, there's a lot of the narrative around economics can both be very powerful and very toxic depending on how it's used, because oftentimes I would argue that economics is at its best thought of as a positive framework for thinking about how different people behave, but often it's sold as a normative framework around who deserves what.
By the way, you're hitting about 12. You could be plagiarizing, like 12 PowerPoint bullets from my last lecture. But one of the points that I think is very pertinent in what you just said is the relevant supply and demand elasticities for some of these things would be critical for understanding what we thought about some of these policies. Like minimum wage, if you have a really elastic supply and demand curve for labor, wow, you're going to have some really big distortions if you have a really generous minimum wage that could make that an unwise policy. If in fact supply and demand are relatively inelastic, then it's really then it looks a lot more like a transfer, to workers, and the employment effects will be minimal. And so there's empirical questions that kind of go into that. Right. One has to think about the actual incidence of the policy, which becomes an empirical question.
And as an aside, in a world where everybody, so just to give you an example, and I will make a case that is more illustrative than concrete, but you asked about providing care in the safety net, or the providers that are serving disadvantaged populations. The challenge that everybody in the healthcare sector faces across the board, be it nursing homes, home care agencies, hospitals, is labor. This is true outside of healthcare as well, getting pilots, right? And the challenge that's driving up prices. the distributional consequences of inflation are actually very important. And so when one puts in place policies like the minimum wage, you don't only have to worry about the employment issues, you have to worry about the pricing issues.
Yes.
When one puts in policies around free trade or not free trade, you want to protect this industry because people work in that industry. Reasonable view. You have to think about what does that mean for inflation and how it plays out. And when one does a lot of stimulus to support different populations, you run into problems with what that means for inflation and government fiscal footing. And I think if you follow what happened in the UK, and by and large I haven't, you'll see that through some combination of spending and tax cuts that were not funded, you ran into a particularly challenging economic situation in ways that transcended any of the specific policies. And so it is important to know the elasticities, like the labor supply and demand elasticities, but it's also important to understand that there's broader issues at play for how these things play out in the economy.
Yeah, so like poor people like to buy hamburgers at McDonald's the same way that Harold Pollack does. And so there's a distributional consequence. If McDonald's is very labor intensive near the minimum wage, price of hamburgers goes up. That's just that. I mean, I'm saying that that's decisive in that case, but that one needs to consider. And if we're talking about, say, childcare, where you could imagine that we want to raise the wages of childcare workers for all sorts of really good reasons. That, of course, has an impact on the affordability of childcare for largely for women who that is something that has to be thought about.
And any policy that affects the labor supply for the type of people that are providing those types of policies, those types of services, ends up being really important. Making sure we have enough childcare workers is important. And if there are policies that discourage people from taking those jobs, for whatever those policies happen to be, you have to think about the impact on those individuals that might be better off because they don't have to take a job in, working in for childcare, working is the parent of someone who does that, but working for care delivery, like just providing home care, is a really challenging job. It's a physically demanding job. It's emotionally demanding job. And any policies we have, including immigration policy and a bunch of other policies that influence the labor supply for those types of services, influence not just the people using those services, but they influence a whole range of other sets of activities. If you pull people away from childcare into nursing, can't get enough childcare, that affects all the people that need childcare to allow them to go to work. It affects the fertility of individuals. There's an enormous amount of connection that you'll see in economics, and most policy can't quantify all those impacts, but I do think understanding them is useful to having a policy discussion, and it helps keep people away from making blanket statements that involve some version of a free lunch. The world would just be better if we did X.
By the way, Vincent's on the call here, and you can wave if you want. One of the challenges that we've had with Vincent's care is that as say minimum wage goes up in around Chicagoland, it does affect the ability to recruit direct care workers in the community integrated living arrangements and other services for people with disabilities. And
Absolutely.
That is
Absolutely.
very challenging job roles. So one of the things that we saw during COVID was very high rates of COVID non-vaccination in the organizations that provide this care. And they just could not, it was an interesting thing because workers had significant amount of bargaining power and many did not want to get vaccinated. And it was actually a formal requirement, but it was one that was largely not met. And basically there was no, employers were not in a position to demand that of the workforce because of because it's just a real given the wages that are paid and the labor market conditions, they could not credibly threaten to terminate workers who did not get vaccinated against COVID, and that was I and others witnessed some of the consequences of that over time, and it was. Many of the workers also do not get flu vaccinations for some of the same issues. Now, one thing I want to be respectful of your time. are there areas of economics that, as you've done policy work, you sort of say, this aspect of my economics training turned out to not be so helpful, or the economic framework turned out to be a little misleading when I went to policy, that people should be mindful of as they try to do policy analysis and apply economics in a sensible way?
Yeah. Well, I'll say two things in response to that question. Actually, three. First, I'm happy to talk as long as you like to talk. It is always a pleasure. That part aside, one of the challenges, I think, it's not so much the part that's useful or not useful, is there's a lot of people who do economic analysis based on what I call economics 101, sort of classic supply and demand, equilibrium economics. And I think if you were just to have economics 101, you would learn, and I think appropriately so, sort of the beauty of the way markets work, and an appreciation for markets, and an appreciation of looking at the world through the incentives that different programs create. I think that matters. But oftentimes, those analyses don't go so far as to get to what I would call economics 102, where you learn about all the market failures. So monopoly power, externalities, public goods, a whole bunch of things that I think economics would teach you and that are actually quite useful, but oftentimes are missing from aspects of the policy debate. The other thing that I would say about economics, and again, this is more degree as opposed to sort of a yes, no, is I guess for your students, it's been quite stylish now for economics papers in the economic profession to do what are known as welfare calculations. So welfare calculations in the context of economics involve understanding whether or not the population writ large, society, would be better off if you do policy one versus policy two. And to do those welfare calculations, you have to use a fundamental premise behind a lot of classical economics, which is relying on revealed preference to estimate value. So if someone buys something, you assume that the price they pay for that is at least as high. I mean, their value of the thing is at least as high as the price they pay for it. And that underlies a lot of his welfare economics. My view of policy in general has been policymakers are much, much more interested in a range of distributional factors. So economics tends to balance efficiency, sometimes with equity, sometimes not with equity. There's a very specific view of equity often in economics. And I would say in the policy space, people are very, very focused on the distributional consequences. The other thing that tends to happen if you rely too heavily on economics is the down weighting of the implementation of the transaction costs associated with particular policies. So you tend to assume, a good example would be payment reform. I work in terms of payment reform. People assume that if you change the payment incentives, all of a sudden the waste will go away. An enormous amount of waste does not go away when you change the payment incentives because organizations are very complex. So I think the work on doing welfare calculations is by and large not necessary for most policy debates. People have.
But when you said organizations are very complex, one of the things I remember, I was at a lecture, and my colleague David Meltzer, who I work closely with, was at, and somebody said the incentives facing the hospital, and David raised his hand. He said, the hospital is not a unitary thing. There really is, there's all these different parts of the hospital that have totally different incentives that exist in this ecology that is, the University of Chicago Medical Center, and that. I mean, one of the things, when I thought about the financial crisis, when we think about large financial institutions and their complexities, you might say, how could we possibly have had, I remember like in 2005, you might have said, to believe that a bunch of things, that we have a serious risk of a bunch of things happening, you'd have to believe that trillion-dollar institutions would recklessly risk billions of dollars, in this way that makes no sense. And it turns out, well, the institution as a whole would never do that. But it turns out that there's this part of the institution where people really did face very practical incentives to take big risks that were not fully understood, even within that organization, perhaps. And that we have to really understand organizations and how they're, and the day-to-day realities of those in order to really understand what the incentives are that face particular actors that are, say, is the cancer surgeon going to do X? you can't sort of say what's the incentives facing the University of Chicago Medical Center. You really have to understand, well, in the cancer center, this is kind of how it works, and this is
That's
how
right.
you know.
And I will say that economics doesn't put a lot of emphasis on issues of power, for example, within organizations. So what role does the hospital administrators have versus the physicians, for example? And how do they manage that? They don't put a lot of incentive on just honestly the competence of the managerial team within organizations. But there's other examples. If you look at the benefits in the Affordable Care Act and you ask, well, what benefits should we give? The economics framework tends to focus on risk mitigation and insurance for this reason. But a lot of what happens in the decisions about benefits are done through a stakeholder type analysis, which is fine. But what that tends to do is push you towards benefits like well visits. And I'm not anti-well visit, but I think we could agree that well visits are probably less important for a population health than, say, certain types of insulin would be an example, but also HIV treatments or a bunch of other things. So we've argued that some of these rare but very important services should face very good coverage, but they don't have big constituents. So you tend to find policy things that seem odd at the outset. The donut hole. Why do we have the donut hole the way we've defined the Part D drug benefits? Well, you needed to have some range of coverage that benefited a lot of people to get their support. Then a donut hole to save some money, then the insurance component layered on top of that, and you end up with this very odd sort of standard benefit package because of that. And I think the economics point is you need to understand incentives. The policy point is, and you need to understand politics, because a lot of these decisions, in fact, I think one of the things that you get wrong, say in the Affordable Care Act about the ACA and broccoli, is healthcare is very unique in the following sense. The cost of providing the services depends who buys it. So for most services, this laptop that I'm talking to you on, all the books behind me and stuff, all those things, the cost of producing them didn't depend on whether I bought them or you bought them or Vincent bought them or anyone in your class bought them. There was a cost of producing them. But when you buy health insurance, the cost of that health insurance depends on who else buys it. And so healthcare and public health in general, I would say more broadly, is a collective issue. Issues of vaccination are a collective issue. And so what a lot of these things that have become problematic and hot-button issues in healthcare have in common is the collectiveness of the nature of the product challenges core values about individual freedoms, about what you are or are allowed to do and how you may or may not want to be free to enter into a contract with someone to buy a crappy health insurance product, for example, or to not get vaccinated, for example. The problem, if getting vaccinated was really only about your risk, I think it would be a lot less controversial. We would let people just decide. I think the challenge here has been the vaccination is central to a whole range of other things. And how do we societally force or not force people to make decisions that may not be what they perceive to be in their best interest to support a societal interest is really an issue that is important and a little bit outside of what I think even Economics 102 gets at, maybe a little public good stuff, externality stuff.
Yeah, it is so many themes in what you just said. But one of the interesting things about COVID is the way that it flips some of the narratives around individual responsibility. So I actually had an op-ed in the Washington Post where I said liberals and conservatives need to learn from each other about how we respond when the unvaccinated person shows up with COVID in the emergency department, and the bellicose unvaccinated patient shows up and has a serious COVID-related challenge. And a lot of my liberal friends are like, that person has been a total jerk. He didn't get vaccinated because he was watching, Tucker Carlson or whatever, and it's kind of on him. And I don't want my mom to be waiting. I don't want him to be taking up resources in the emergency department or in the ICU that my mom needs, who's 90 years old. And a lot of conservatives are like, that's his, we cannot, he's sick, you can't do that. And they both kind of have a point, but we've sort of flipped the usual way this conversation goes, which is,
right.
Very often, the usual liberal position is it's not my, this person has a need. He's a human being. It's not my job in this moment to morally sit in judgment on this person. And the conservative is like, well, people are personal responsibility and there are consequences to choices that we make. And And it's interesting, when it was flipped, both sides were kind of uncomfortable with the implications of that.
That's right. And again, so in a smaller context, you hear this discussion around motorcycle helmets, for example. Who's responsible for those types of things? And I think that where economics is actually quite useful is sometimes you can solve this by how you set the prices. So how do you feel about charging smokers more for insurance? How do you feel about charging uninsured people for care for illnesses that they could have prevented had they acted in some sense more responsibly? But these are complicated distributional issues. So to get back to my earlier point, this becomes a challenge for the economics paradigm because it doesn't deal well with these distributional issues, particularly around the transfer, about who, we don't spend a lot of time thinking about the politics. Economics doesn't spend a lot of time. I would say politics spends a lot of time. Economics doesn't spend a lot of time thinking about the politics of the actual transfers. Who's paying for whom? How do we think about Medicaid, and we need to design Medicaid in a particular way. We know the politics around Medicaid often becomes controversial, and for a whole bunch of reasons, but a lot of that, the transfer component of Medicaid gets to this core question of what the societal bargain is. And so I asked my class years ago if healthcare was a right. Everybody says yes. No, to your point, no one says healthcare is not a right. They debate on what's actually healthcare.
Yeah, so is supportive housing, the air conditioner is a great example.
The air conditioner is a good example, but even end of life care. So you have a right to healthcare. Do you have a right to have care that we know is not going to be effective at sustaining your life, but is very, very, very expensive, which you have a right to have it? Do you have a right to have someone else pay for it? And there's a bunch of other hot button issues that would fit into that paradigm that I'm going to ignore on this Zoom, but I could give you a bunch of where people don't want to pay for other people to get services that they don't support.
Well, by the way, the other thing implicit in our conversation, which we won't be able to go into in detail here, is sort of the political economy issue. And one of the ironies when you talk about who's going to pay for stuff is a Medicare official in the George W. Bush administration and the Obama administration probably have more in common with each other than either does with a congressional committee chair of either party. Say we're debating, like Medtronic has some sort of a medical device that is of kind of marginal cost effectiveness, and there's a debate about whether Medicare should pay for it. The reality is that, the Bush official and the Obama official might say, I really don't know that this is worth it for Medicare, but the Minnesota congressperson of whichever party is, who happens to be where Medtronic is located, is going to push for that heavily. And they do not want to see some sort of a cost effectiveness standard applied that is going to hurt first of all, will hurt their constituency. Secondly, it deprives them of the opportunity to do a favor for a constituent that they can then take credit for, when they're looking for campaign contributions for their next campaign. And it does, it's sort of striking how like some of the most liberal single payer advocate representatives in Congress, you look and they're pushing for, really poorly justified, reimbursement for poorly justified things, that are for a manufacturer in their district or something like that. And it's just the way the system is set up. That's what you do.
Yeah, and I'll leave the political economy to you. There are certainly a lot of challenges in how we implement all of these policies, and a lot of pressures that range from representing your area, your district, and varying things to genuine disagreements about how the role of the government, what the role of the government should be. And particularly cost effectiveness is a great one. What role we should, cost effectiveness should play in how we allocate resources in this country. And for that matter, more broadly, and remember, I do chair MedPAC, I think there are challenges around what role the government should have in our healthcare system. I think that's why within MedPAC, for example, we try and avoid broad questions around the scope of the Medicare program and focus on taking the Medicare program we have and making it operate as efficiently as we can. And what's nice, of course, about MedPAC is that it's nonpartisan, it's analytical, and the policymakers will react to the information we provide as they see fit. but you do see they do face a lot of pressures from constituents across the board. And it is a really challenging job in many ways. And you see both the good and the bad of how that part of the system's set up.
Yeah, but just if I'm a random congressperson, I sort of say, here's this thing that creates a centralized analytic platform that tries to establish a common metric for evaluating the justification for reimbursing certain services or not. I totally understand the need for that, and I totally understand why I want to fight that, because there's going to be times when I want to, when my parochial needs are different, my own incentives as a legislator are going to be different.
And although there's a lot of things, Part D reform, rural emergency hospitals, you see places where people can come together and get some of these things done, and you see places where they don't. And you see places, a good example of Medicare Advantage, where there are really different visions about the role that Medicare Advantage plans should play in the Medicare program. I have to say, honestly, I wouldn't dismiss the argument that the core politics you discussed play a role in that. But I also think there's core value differences that play a role in that as well, for how people view that question. And so, yes, I will avoid the politics of all of this, but I think the economics is complicated enough for me.
By the way, one of the areas where my own priors have moved is in Medicare Advantage. I did a study with Kenton Johnston and a couple of colleagues. We've done a couple of studies, Hefe Wen, and where we compared services for people with intellectual disabilities in Medicare Advantage and in traditional Medicare. And what we found was that the Medicare Advantage actually did really pretty well. And I kind of came into it with some assumptions that turned out to be wrong. That it turns out, like, you just look at who gets a colonoscopy, who gets basic screening services. Medicare Advantage was doing a lot better. And
it does.
And I was really impressed by that. And actually it leads me to my final question to you. Is there something where you've changed your mind over the years, seeing the data, that you sort of came in with a strong set of priors? It just turned out to be, when you looked at the data, you realized, I was mistaken about that.
So I will ponder that for a second, but let me just say one thing about Medicare Advantage. It is two things are possible, although it's hard for folks to hold both of these things in the front of their mind. Thing number one is that Medicare Advantage does a very good job at providing services to populations that need it in a range of ways. And I agree with you. We've done some work looking at mortality effects and other health effects of Medicare Advantage plans. So I think broadly speaking, the literature supports high quality care on Medicare Advantage plans. And for those people that are very anti-insured, that's a harder thing to swallow. It's also possible that Medicare Advantage plans are overpaid. You see this, drugs are very important. We mentioned insulin, there's a lot of drugs, COVID vaccines, COVID treatments, innovation in drugs are very important. That doesn't mean that we might not be overpaying for drugs. And you have to think about what the elasticities around innovation are, for example.
Yeah.
So with regards to your specific question, areas where I changed my mind, we should have prepped for this more later, and I'll kick myself, but I will give you an answer that is relevant.
Sorry, I should have told you I was going to ask you that question.
I'm going to give, no, that's all right. I wouldn't have, we've been in the Berkshires. I wouldn't have really figured it out, but I'm going to give you an answer that's very Herald specific, because this is actually a lesson I learned from you in one of our very early conversations when I was thinking about a range of policy options. And what you pointed out, which I think has become increasingly clear to me is true and underappreciated by me at the time, is to think about the behaviors that individuals take in the context of their entire lives, not just in the context of the incentives that you give them. So a lot of this is morphed in a whole range of other ways to things like behavioral economics, but in a much more broader sense, people's lives are very complex. And oftentimes policy makers think of policy solutions in a very narrow way, give them information, they will view that information, they will respond to that information, set up the prices, they will respond to that information and those prices in a very rational way. And in the broad scheme of things, it is true that if you charge people more, they buy less. They often respond to information in particular ways. But in many, many situations, what you need to really appreciate is that people's lives are very complex. They face a lot of challenges. There's a lot of things going on. So whereas you might think it's completely rational for them to, I don't know, quit smoking, we had this conversation, actually probably came up in the context of SIDS when my kids were young, and it might have made complete sense to have my daughter sleep on her back, but she would only sleep on her stomach. And you know what, given everything else that was going on in her life, I had all the information, wasn't a price issue. We let her sleep on her stomach. But I think a lot of people face, when we deal with this about getting people to sign up for insurance in the connector, it is a much more complicated issue than to say, we're now subsidizing your insurance, it's a great deal. You can see the same in Medicaid take-up. Right.
Mhm.
So I think when I started out with my training in economics, I was much more willing to buy into the connection between people responding to their incentives. And by the way, I do believe people respond to incentives, just to be super clear. There's nothing that I say that I want to have anyone infer people don't respond to incentives, but they do so in very complicated contexts. And I increasingly appreciate the importance of those contexts as much as simply the incentives you're giving them. And I think I underappreciated that for a fair bit of time.
There's a couple of different ways to deepen that. And I think in the social work context, people should certainly appreciate that. One is how difficult it is to fully understand what the incentives are, and how much bandwidth you have to fully process that. The idea, you could find it. All you have to do, you can find a cheaper incentive plan. All you have to do is spend 4 hours cruising around on the web, getting information from some website that you've never heard of before. If that's the choice architecture, of course, a ton of people will never do it. And in fact, we know, I mean, for my students who are concerned about voting rights, obviously one of the ways this shows up that links to Pam Hurd and Don Moynihan's work on administrative burden is, you say anybody has the right to vote. All you have to do to vote is do the following 12 things, and then anybody can register to vote. And if you didn't do that, and you didn't, you didn't get registered, that's on you. And the fact that we kind of programmed that up because we kind of predicted who was not going to bother going through all 12 steps, we'll sort of leave that. I'll leave the reader to fill the rest of that in. The other is how we need to have a certain amount of empathy for people who make what appear to be suboptimal decisions, because it is, one of the things that I think, especially when people are in vulnerable circumstances, it is really, really hard to do everything as optimally as you would like to ideally do. And I remember when you and I knew each other well when I was in Ann Arbor, Veronica and I, we didn't, I remember we sometimes ran up a credit card debt, and it was clearly poor. We clearly were spending a lot of money on.
Is this on your cards? Is this on your note card?
Yes.
Not to do.
Yes, absolutely. And it was just, we were really, we were strapped, and we often, we were worried about making it to the end of the month with all of our financial stuff going on, whatever. And we couldn't always make the optimal decision. And you have, like when you said you put, you didn't always put your child in the optimal position sleeping. That is human, and we have a lot of, I do a lot of work with people in the criminal justice system, or people with addiction issues and so on. People don't always do the optimal thing. And it's very easy, especially if it goes badly, for us to really sit in judgment on that. And I mean, I think it's appropriate to have personal responsibility and say certain things you shouldn't be doing. If you had a 6-pack of beer and then started driving your car down the street, don't do that. But the idea that you're not going to optimize everything all the time with everything else going on in your life is a very human insight.
No, that's right.
Very long, very verbose way to get to an obvious point. But
no, well, I think that's true. And I think the challenge in economics, of course, is who's responsible if you don't respond to incentives as you should. So I think there's a difference between being empathetic for people that aren't reacting the way they should, designing the choice architecture in a way to support that, versus making it okay if they do it. When I worked in a soup kitchen, I think one of the things early I was thinking was, if we just could take these people and give them jobs and whatever, then they would behave in a way that I think they would like. But there was a whole lot of other issues that many of those people were facing that made their lives and the policy responses more complicated than just changing the incentives they faced. And that is where I think, you see well, I'll say one thing is I get the sense we're getting through your questions.
Mhm.
Economics provides a framework for thinking about a lot of things, and economists over the years have been remarkably creative at expanding that framework beyond what people typically think of as classic economics. But with all of that framework, we don't do a great job of answering really sort of the fundamental societal questions about how responsible are all of us for each other. How much should we moderate the risk that individual people take if they take certain behaviors? How much should we do this in a pure program evaluation way? If we create a needle exchange program, to pick a topic that you know a lot about, how should we just ask the questions? What's the cost of it? What's the benefit of it? With an expanded sense of where all the incentives are around the needle exchange program, versus how much should we imply a value judgment about a whole range of aspects related to that. Those are things that transcend economics, and I think they're very important questions. I won't take a position. I've tried to be very careful not to take any important position, so I hope I haven't bored everybody who's listening. But I think economics as a discipline provides a framework for thinking about that, but the framework itself can't give you the answers. And when economists talk as if it does, you should be pretty skeptical.
That's a great point. By the way, I would say part of program evaluation is also to understand how are people actually responding to the incentives. So suppose we do a program and we discover 42% of the people seem to be responding in a suboptimal way to the incentives that we're trying to create. That's probably a good reason to say, okay, how do we redesign the way that this program presents itself to people so that more people are responding in a way that we believe is the appropriate response. So maybe like when I look, one of the things that we, I'll end on, I'll release you momentarily. I'm doing a current project on something called ABLE accounts, which are accounts for people with disabilities that allow people to avoid to save money in a legitimate way that gets around the accountable asset limit for SSI and Medicaid. And there's a $2,000 asset limit for which is very punishing for people. And it turns out if you look at who has ABLE accounts, I would say 94% of all of the ABLE accounts in Illinois are held in affluent zip codes. There are for young adults with intellectual disabilities who have high SES family members who have set these up. And if you go to the website for Illinois ABLE accounts and you just start reading, like Mike Chernew would actually find this incredibly transparent. It looks like the financial forms that you get from your normal investments as an upper middle class college professor. If you sort of say, how are people who do not live that life going to respond? It's completely predictable that it's incredibly intimidating. A lot of people are like, this looks like it could cause a problem for me, and I'm reading all this financial gobbledygook. I'm just not going to do this. And by the way, I also don't have money to put into the account, but even independent of that. And that to me it's a program failure, because we've created a very predictable set of administrative burdens that are going to mean that a particular slice of the population is going to take advantage of this program and a particular population won't. And one of our jobs as policy people is to bring the behavioral economics and the administrative burden perspective in, and the cultural competence piece in, to say, how do we actually present programs to people so that they can understand and react to the incentives the way that we hope and believe that they would. So that was very verbose, but
I agree. I have a former student now who's looking into the administrative burdens on patients and interacting with the healthcare system.
So I hope to have Pam Hurd as another one of these conversations, but in order for that to happen, I have to actually stop talking to you. So I'm going to stop the recording.